We now move on to the panel discussion on diabetes-specific nutrition, the missing link in comprehensive diabetes care, which will be taken forward by Dr. V.Mohan, sir.
So, welcome everybody. This morning we had a session by Dr. Anjana on some very novel findings from the ICMR INDIAB study, which is getting published in Nature Medicine quite soon. Next 2 weeks or 3 weeks, you'll see it in print. It's going to be a game changer because for the first time, every state in India studied finding out what our nutritional needs are. And so in line with that, and she talked about protein, using the right carbs, and everything that she brought out as policy needs has to be implemented in some way. And she also clearly brought out that Indians take too much of carbs, wrong carbs, protein also is not sufficient, fiber is not sufficient, all those things. So today, in people with diabetes, there is something called as diabetes-specific nutrition. And that's what we are going to talk about. You can skip that and go to the next slide. So what I'm going to do is, this is a panel discussion. So we're going to sit here and talk. Can we finish off I wanted to change the order and give the mementos first. So can I do that? Just for a change. We'll go there. You both. Two wonderful panelists here, so I thought we'll start by giving them their Okay. So the way we're going to do this is, I'm just going to give 3 or 4 introductory slides, and then I'm going to ask both Dr. Shashank Joshi and Dr. J.Lakhani questions, and then after they finish their round of questions, then we'll open it up to the floor, and you can ask anything about diabetes-specific nutrition or anything related to that. So next slide. Oh, I have it here, so I'm supposed to do it here. Okay, so that's a disclaimer that is supposed to be added. Okay, so throughout this meeting and throughout any diabetes meeting that you go to now, you're going to hear a lot about weight reducing medicines, GLPs, okay, and SGLT2s. So with that, some of the questions which people start asking is, now that you've got a drug to reduce weight, every conference people are asking this. Do you still have to do diet and exercise and just take one weekly shot and it's done, finished, or daily shot and then it's done? That's what people say. I would put it to you that if at all, it's the other way around. Now you have to look at your nutrition even better. Otherwise you're going to develop sarcopenia and so on. If you look at this graph here, you'll see that the weight comes down, and of course there is loss of fat with these drugs, there's no doubt about it. Lot of weight loss, HbA1c comes down, there's a lot of fat, but you're also losing muscle, okay? So for vegetarians who will find it, how much legumes can you take? You'll get flatulence all the time if you take that. Non-vegetarians cannot take, vegetarian cannot even take egg. I tell them, at least one egg white you take. No, we are strict vegetarians, we cannot take. So I struggle how to increase the protein intake, how to give them healthy carbs. So this so-called diabetes-specific nutrition, which they'll be talking about, has all the right ingredients. So here is a patient whose weight has come down from 114 to 60 after bariatric surgery, and later it increased to 83. Now he is on semaglutide and the weight has further come down. But what happens is that they also lose muscle, as you can see there. So how do you preserve this muscle mass, not just for those who are taking these drugs, but in general for people who are on a diet? And that's where the meal replacement with the protein comes in. So I'm going to start with Dr. J.Lakhani and say, what can be done for this patient? This patient has been taking some, first he had bariatric surgery, then he had semaglutide, and he's losing weight, but along with that he's also losing other parts. He's losing muscle and so on. So what would be your approach to this?
So thank you, sir, and thank you for having me for this conference. I think, if we prolong this too long, we are actually going to do meal replacement. You're going to replace your meal with academics. So yeah, so it's a very relevant and contemporary question. You'll actually see patients like this who are now going to lose weight with the newer anti-obesity medications, and then they'll regain a bit of the weight. Now, one of the reasons why they regain this weight is because of the loss of the lean body mass, especially with the bariatric surgery. As you saw, he went to 60 and then went back to 83. So there was a regain. A lot of it would be because of the fact that he also lost a significant amount of muscle chunk, which also kind of attributed to the the weight being regained over a period of time because the homeostatic mechanisms. So in today's world, hence I think nutrition plays even more importance because now we'll have a bunch of patients who are going to lose weight and then they will be at a risk of regaining the same. So I think that's where something like a diabetes specific nutrition is really important. So today we are in this panel, we're going to cover a lot of these aspects. We'll see what exactly is a diabetes specific nutrition. We'll also see what we'll do in patients like these, and we'll see what are the strategies which you can use in terms of the DSN as well. So that's what we're going to do. But if we talk about this patient in particular, now the patient has regained the weight. I'm very sure that he would have lost muscle mass, and there are a lot of talks on SGLT2 also. Another agent which particularly produces a lot of muscle mass loss is SGLT2, right? So because a lot of your patients lose weight there as well, but they also lose muscle mass. So I think it's very important that we supplement them with a good quality nutrition which contains a lot of proteins and less of carbs, which is what is the need of the hour. Now, what exactly is well, this is quote unquote diabetes specific nutrition, right? Yes, sir. So yeah, so I just finish this by saying that for a patient like this, some sort of a strategy has to be devised which can help the patient kind of maintain the muscle mass, at the same time not regain the fat mass which he has made a lot of efforts to lose. And I think that is where something like a diabetes specific nutrition will come.
So turning over to Dr. Shashank Joshi. So we know that meal replacement on one side is there, then you have meal supplements as a second one, and now we are talking about diabetes specific nutrition supplements. So these are all terms that we hear. Can you clarify them for the audience so that they know exactly what a DSN or a diabetes specific nutrition is?
So before I do that, just a small comment on the case. Though we are here in a nutrition symposium, muscle mass is best preserved by strength training exercises, and muscle strength training exercises is the key. So resistance exercises, whether you do a Kapalbhati, whether you do a Surya Namaskar, whether you do Uthak Baitak, whether you go to a gym, whether you lift muscles, or whether you did the exercises which were muscle strengthening exercises in the morning during the plenary session, they also strengthen your all muscle groups. So muscle strengthening exercises with adequate balanced nutrition including proteins is the key. And the point is that there is a clear-cut term defined by all global bodies called diabetic specific nutrition. And this diabetic specific nutrition is nothing but a specialized form of therapy which has the right amount of macro and micronutrient ingredients which will manage malnutrition. Now in India, we get all types of patients. We get a lean person. In fact, Dr. Mohan's group is likely to publish very soon the lean variant of diabetes. In India, we get lean variant. In the good old days, people used to call it MRDM. Somebody has surreptitiously named it as type 5 diabetes. But I don't agree with that. Neither does Professor Mohan. So, whether you are lean, whether you are normal weight, whether you are having abdominal obesity or whether you are having obesity, all of them can get diabetes. This diabetic specific nutrition is nothing but a macro micronutrient ingredients which manage malnutrition, glucose and other cardiometabolic risks. What do these formulas have? These are evidence based formulas. So they have something, and David Jenkins, who discovered the glycemic index, and me and Dr. Mohan had a fortune to meet him in New York a couple of years back, almost 2 decades back. He used to call them lente carbohydrates. What is lente carbohydrates? Long acting carbohydrates, slow release carbohydrate blend, where there is a lot of fiber. So it's called as a slow release blend with high dietary fiber with a lot of high quantity protein. In the morning, Anjana very nicely told us that we need proteins, we need fibers, and we need a slow acting carb. With that, there is a fat blend, and the fat blend is mainly of MUFA-PUFA mix. Mainly the MCTs, because MCTs are needed. You know, it's not that we don't need fat, but we need the right fat at the right place with a lot of micronutrients, which has to be lactose and gluten free, with low GI and GL, and this can be used. Mainly we use this, most people think we use this for enteral and parenteral nutrition. That is very correct. We do use them for enteral and parenteral nutrition, but this can be used in community also, in office practice also, and special populations like pregnancy, lactation also can be done. So these are clinically proven diabetic specific formulas with outcomes, just like we have drugs where there are positive outcomes, like you just had beautiful talks on SGLT2 inhibitors or gliptins or the GLP-1 analogs in this conference. Even diabetic specific nutritional formulas are evidence based, they are clinically proven. For example, Professor Mohan has done a very, very nice study on, say, one of the formulas which he'll allude to, and I would like him to give a little data on that, and that will have glycemic control, weight management, and these are robust studies nationally. Even we have done some studies. Globally, there are studies which are available. So, diabetic specific nutrition and diabetic specific nutritional formulas are nothing but formulas which are meant for all types of phenotypes of diabetes, whether you are lean, normal weight or overweight, and they control glycemic variability. They have a slow release carbohydrate system with fiber, with protein, with fat blend, which is the right mix of MUFA and PUFA, with micronutrients which are lactose free and gluten free, with low glycemic load. And they can be used in enteral, in hospital, parenteral, as well as in special situations, as well as community practice, and they have RCTs backing them up. So that is really the definition of diabetic specific nutrition. Now many formulas are available. So how are they different? Well, they have low glycemic load, they are complex carbs with high fiber, protein and MUFA. They are clinically studied with outcomes both for weight and glucose management, and therefore in that patient you can often co-prescribe. In fact, I am using it very regularly now because I use a lot of GLP-1. So is OM, so is Professor Mohan and all of you all. Remember, when we are using these GLP-1 agents like oral semaglutide, injectable semaglutide or injectable tirzepatide, we need to co-prescribe them with these agents because they will lose muscle mass, and otherwise certainly you will see that they have become aged, they will get wrinkles, and you are seeing some of these Bollywood stars having that. It's also, remember that we can lose, Dr. Mohan used the word supplement or replacement. So you can use it as a part or total replacement. Right now, instead of having food, you can have it. If you don't want to have the full food, you can have half of the supplement and half of the food. And most importantly, in our country, a lot of lactose and gluten-free situation is there. So that's a little snapshot about diabetic specific nutrition and diabetic specific nutritional formulas. These are designed, these are available, these are globally approved by FDAs, and we have also done original studies. I would just like Dr. Mohan to give a little glimpse about his study which he did about this compound.
Thank you, Shashank. I think that is a very good thing. So one of the takeaways from what he said is that it may sound very strange, but people who want to lose weight can use it. People who want to gain weight can also use it. You may say it's very funny. How can it be? For gaining weight and for losing weight. For gaining weight, you add as a supplement. You don't have to replace. When you want to lose weight, you replace your food. Instead of taking 400, 500 calories, you take something which is measured calorie, 200, 140 calorie, whatever it is. If you take that, you're getting the right supplement with all the right nutrition, with the carbohydrate which is not going to increase your sugar, with the right dietary fiber which we talked about in the morning. Dietary fiber or dietary protein only is going to help you. Dietary fiber is also increased in that. The fat is the right fat. It has MUFA, PUFA. So in whichever way you see, as he said, these are tailored ones. They didn't come by accident. Somebody just discovered one. They were actually produced, saying that all these criteria have to be met. Every box has to be ticked. And that is how it is. So in our study, what we found was great things. The people lost weight, the waist circumference came down, and HbA1c improved, lipids improved. So all the cardiometabolic things that you want, and it also depended on how many. We did it for obese and overweight people. So the more they replace, if they replace one meal, they got some effect. If they replace 2 meals, then obviously they got much better effect. So these are all published in very standard international peer-reviewed journals. So now let me switch to Dr. J.Lakhani and ask him, okay, so Dr. Shashank mentioned the diabetes, what is diabetes specific nutrition, DSN, for whom and for how much?
Right. So, like Sir said, these are the three situations. Let me give you some case examples of that real life. So, you have three situations. One, you have a patient who is, underweight, right? For example, we have this young type 1 diabetic patient, she's 17. With the initial period, she lost a lot of weight. She's currently quite lean. Her BMI is around 17. And obviously, she's doing very well with her diabetes management as of now, but that weight becomes a little bit of a concern for her. Now, we want to give her something which is going to help her, but at the same time not increase her blood sugar, right? So what we have started doing is, in between her meals, we have started, now she's going to college, so in between, she has that time. So in between her meals, we have started supplementing additionally with a diabetes-specific nutrition. So for that underweight type 1 girl, what we are doing is, we are adding an additional meal which is low glycemic index, which will not increase her blood sugar, and she'll probably not need an insulin shot before that, but at the same time will give her adequate proteins to help her supplement her thing. Now, somebody who is normal weight but has uncontrolled diabetes, and we have plenty of those patients in my state, and Dr. Joshi also practices in Mumbai. He has a lot of Gujarati patients, and I'll tell you, if you ever, seen a Gujarati patient, well, their sacrosanct meal is an evening snack. Right, so if you see any CGM, well, when I started practice in Ahmedabad, I realized that you see every CGM, there's a big bump at 4 o'clock in the afternoon, right? You realize what is this, right? And you realize that at 4 o'clock in the afternoon they have their best meal of the day, which is an evening snack, right? Which they can't live without, right? So a lot of these patients, you see their fasting blood sugar, it's fine, post meal sugar is fine, but when you put the CGM, it's that evening meal or snack where the blood sugars are pretty much high. So what we have started doing is, we have started doing a partial meal replacement, where we are saying that, okay, fine, I know that, it's very difficult to get rid of your habit, but in a sense, let's replace that evening snack with probably a diabetes specific nutrition. Or sometimes they have a very heavy sort of a brunch kind of thing in the morning. So tell them, you start with a meal replacement, right? So instead of taking that first bite of food which you're going to have, why don't you start with a glass of Ensure Diabetes, and in that sense, that reduces the overall, improves the satiety of the patient, reduces the next food intake. And if you see a lot of studies, and now we are in the era where we are dealing with a lot of obesity patients per se, just obesity. What we realize is that the sequence of the food you take in the meal is also very important, right? So instead of starting with a carbohydrate, if you start with a protein or you start with a fiber, that increases the satiety, and subsequent meal reduction, subsequent food which the patient is going to take will also reduce, right? So gone are the days when the hotels do exactly the opposite, right? Restaurants do the opposite. They give you an appetizer. They want you to eat more. But what you should be doing as a doctor is to do exactly opposite of that. You do a de-appetizer. You give a meal, start your meal with a protein where you have a reduction in the food intake, right? And the third one, I'll tell you an example, just yesterday. So we have this doctor who's a critical care specialist. He's obese. He's 120 kgs. We recently started him on Monjaro, tirzepatide. He's doing very well. He's reducing weight. But he came with the solution himself. He said that the whole day, I'm okay. I have my regular lunch, and of course my quantity of food intake has reduced. But when I go back in the evening, I hardly feel hungry at all, right? I don't feel hungry at all, and yet at the same time, well, habit drives that, you have something. And then I found a solution. I said, what? So I said, I remember telling me about this Ensure Diabetes, diabetes specific nutrition. So in the evening, instead of having a dinner at all, I just take, a glass of this. I feel energetic, I feel, fine. And at the same time, it helps me with my weight loss journey as well. So these are the three strategies. So just to simplify, if you have a patient who is overweight, what you do is you completely replace a meal with a diabetes specific nutrition. If he's diabetic who is generally, who is having high glycemia, but HbA1c is not controlled, but where you just need and the weight is normal, you do a partial meal replacement. So you perhaps start a meal with a thing, or maybe replace a snack with a diabetes specific nutrition. For underweight people, like a type 1 diabetic or nutrition related diabetes, in that cases, what you could do is you could, in between the meal, supplement them with an extra diabetes specific nutrition, which will give you the proteins and the other benefits without increasing your blood sugar.
I think very practical tips. Go on to the next one. So next one, you can take that. Do we have clinical evidence of diabetes? I mentioned briefly my talk, but you've also done work on that. So
So, just like any molecule, these formulas like Ensure Diabetes Care also have evidence base around them. So, in terms of A1C, in terms of weight, in terms of glycemic variability, symptoms, as well as cardiometabolic risk. So, that data does exist. For example, this is data to show that around 0.9% A1C drops down with a diabetic specific formula. So the A1C drop is sustained and the fasting glucose also comes down in overweight and obese adults with type 2 diabetes. So this is data which is there, and this is something which we recognize. Then in terms of weight, you can see another study where they have done structured lifestyle intervention with diabetic specific nutrition and motivational interviewing, and you can very clearly see that there is 7% weight loss and there is almost a 1% reduction in A1C. So they are as good, because remember, when we consume these diabetic specific formulas, they also stimulate physiologically, just like gliptins do, the physiological increase of GLP-1, and that data is also available. And the look ahead study was the one which used Glucerna or Ensure Diabetes Care. You got very, very good weight loss with diabetic specific nutritional formula, up to almost 11.2% reduction in 1 year, and this was very compelling weight loss. And you could see that even after 4 years, people continued using these formulas. When it came to glycemic variability, you could see that the mean amplitude of glycemic variability or excursion came down by almost 17% with diabetic specific nutrition, and this is from Professor Mohan's study, which was published in JAPI a couple of years back, almost 5-7 years back, and very clearly showing that. And then when it comes to symptoms, what is very important is that we all know that we artificially switch off appetite with a semaglutide or a tirzepatide, but actually by giving the diabetic specific nutritional formula, you improve satiety. It gives you a sensation of fullness. So you feel full, so you eat less. For example, if all of you all had a little bit of a Ensure Diabetes Care drink outside, then you will not feel hungry and feel hypoglycemic. Some people I can see they are getting up and going because they are a little hungry, and then they are getting hypoglycemic, which I don't blame them. So clearly we know that these, why do you get satiety? There is data to show that these diabetic specific nutritional formulas improve the secretion of satiety hormones. What are the satiety hormones? The basically glucagon and peptide YY. And mainly because of the macronutrient composition of these diabetic specific nutrition formulas, they stimulate glucagon, they give glycemia and satiety, and they also improve the metabolism and energy expenditure. And finally, in cardiometabolic risk, you can clearly see that it reduces. This is our study which we did, which we presented at ACE. You can see that the glycemic variability comes down, lipid parameters come down in 47 type 2 diabetic subjects with BMI about 25. At the end of 1 year, there was 6.4 kilogram of weight loss. You could see that the glycemic excursions came down, fasting glucose came down, postprandial glucose came down, area under the came down by 64%. Triglycerides came down by almost 69 milligrams, and both lipids and blood pressure also came down. So there was weight loss and there was glycemic variability which reduced, and that's something which we showed very clearly. Also we know that they reduce waist circumference, hip circumference very clearly, and there is a twofold reduction in fat mass and fat free mass. So preservation of muscle mass and reduction of fat mass is something very physiological in diabetic specific formulas, unlike the conventional GLP-1 agents which are coming in.
So I think we'll take this as probably the last question before we open it up. So do you see any role for this? I already mentioned it in those with GLP, the obvious answer, but I'd like you to answer.
Yes, sir. So if we turn back to the original case, we had this patient who, lost weight after bariatric surgery, regained, and now is on a GLP-1. I think in today's world, in fact, don't take my word for it. There are very clear guidelines now with the use of GLP, and there are obesity guidelines also on this area, which clearly say that along with the GLP-1, nutrition is a very important aspect. And when you're giving when the patient is on a weight loss journey, your focus then should be to give nutrition which is high in protein, rich in protein, at the same time has good quality carbohydrates, low GI index carbohydrates, and good quality fats as well. So that's the whole idea. Of course, GLP-1s, there are studies which have shown that the muscle mass loss is not that much, but at the same time there is a muscle mass loss which happens to some extent, because overall patient is losing weight, and in that regards you have to supplement them with some sort of nutrition. Now, so one of the strategies which is going to stay and which is going to to now evolve also, because with the use of GLP-1 would be a addition of diabetes specific nutrition. And my strategy for these patients will be a complete meal replacement strategy, like we did in the young doctor who came to us with 120 kgs. So his evening meal, we are completely replaced with a DSN, which does a lot of things, improves his energy and improves his overall well-being, at the same time does not increase his weight. So that's a good strategy to follow. And I think in this today's era, I think this becomes even more relevant, because you're going to see a slew of patients who are going to come with this problems.
If I can just add to that, apart from the loss of the muscle mass or preserving the fat-free mass, increasing it, and preventing sarcopenia, all over the world, where people in the US, everywhere, it's not just related to cost. After taking the GLP-1s for a year, in fact, the first question people ask, how long have you to take it? They don't ask it when you start statin or BP drug or any other diet. But for this, they're asking, how long? So that itself shows that many are going to drop out. So after 6 months, 1 year, people drop out. Or they reduce the frequency. Instead of taking it once a week, once in 2 weeks, once in 3 weeks, once in 4 weeks. Cost is also a factor, but apart from that also they say, how long I'm going to take this? I've already reduced, I've plateaued out. So when they plateau out, they think, oh, now there's no point taking it. They do forget that it's going to regain. Now, in that situation, not just for meal replacement for the muscle mass, but as a meal, not just supplement, but also as a meal replacement to keep the weight down. Something you need to reduce the weight. So, it doesn't mean that once you do that, you don't need diet or you don't need this. It doesn't mean that. Probably there is an increased role for that. Do you have any other question? Or no? Okay, so I think we have given you an overall idea about the use of diabetic specific nutrition. But we would like, I see a lot of nutritionists in the audience as well. So I would like to ask you to send in your question. It must be more interactive. It can't be just we are just speaking. You've got experts here who have done a lot of work on this. So they are coming around with the cards. Please write your questions and then send them across. Actually, we are extending the session by a few minutes, so to give you a little bit more time, after which you can go for lunch. So, Shashank, this is for you. What is the role of maltodextrins in these preparations? Each formula has specific dose specification, 2 scoops or 3 scoops with water or milk. Does it affect absorption of medications? There are 3 questions. I'll take one more question.
So let me start with these supplements don't affect absorption of medications because these are usually water soluble and their micronutrient formulas don't interfere. So there is no drug to diet formula interaction. Usually we give 2 to 3 scoops with water. Usually milk is avoided, but if you want to have weight gain, that means somebody is underweight, milk may be better. If somebody is overweight, water may be better. And 2 to 3 scoops, but totally we recommend 6 scoops per day. Okay, that is what is there. Maltodextrins is nothing but a modified carb and a slow acting carb, and different preparations have it differently. So it's just one of those additional ingredients which is there as a part of the system. Yeah.
So to Om, would you recommend, it's called Ensure Diabetes Care. So do you recommend it for a non-diabetic? I think they got separate preparation itself for people with
yeah. Yes. So there is Ensure Diabetes without or Ensure Nutrition or Ensure Protein, which is available for non-diabetics. But what I'll suggest is, and what would be my strategy is, if your patient is already pre-diabetic and insulin resistant, probably it would be a good idea to continue the Ensure Diabetes Care preparation. If your patient is completely non-diabetic, HbA1c is completely normal, I think, you have Ensure Protein. There's a separate preparation for patients with chronic kidney disease also from the same company. So I think, depending on the clinical situation, you may prescribe the appropriate, thing. So, but whether a non-diabetic can take it, yes. Whether they should take it, that will depend on the clinical situation. But for pre-diabetics, I think this would be a fair, preparation to be given in those as well. So.
Many non-diabetic patients many times have glycemic variability in obesity and are taking GLP-1 agents, and I'm giving Ensure Diabetes Care to them. It's not necessarily that it has to be only given for that. So there's a very funny question here, that is there a recipe of DSN to be made at home by patients who can't afford commercial preparations. Okay, so but I think we should have a good dialogue and discussion. Honestly, I wish I knew, and sponsors of this talk, Abbott Nutrition will go out of business. But best preparation at home for people who can't afford commercial preparation is drink more water. Water is very free. I don't think we need good pure water, and water if you drink, you feel full. So the strategy is that drink water before a meal. If you drink 2 glasses of water just now, you will not feel as hungry if you did not have water. If you add a little bit of isabgol to that water, okay, you will feel more full, and you might puke a little bit, so it will become like a GLP-1. Okay, so this is my poor man's formula for people who can't afford an insured diabetes care. But it won't be evidence-based. So these are anecdotal, observations which I'm making. Then somebody also asked a question about Musatide. Now this is not a scope of Musatide talk. It's a Chinese drug. Anything made in China, we know how Chinese toys and Chinese watches work. So I would not like to comment on that. I would skip that question. It's a novel agent published in New England Journal of Medicine, and it's a GLP-1 agent. It's a fat loss drug, and it's not available in India. So we have a lot of work in progress, but it's not a nutrition question anyway. And maybe Om, you want to take another couple of questions? Then again, I'll take this one. Dr. Venkateshwar from Hyderabad is asking, Indians are sarcopenic. If you lose lean muscle mass, it is very difficult to get back, and muscle mass is only a predictor of danger. So how to balance? It's a very, very good question. I think this is the core of this talk. I think the biggest challenge with the GLP-1 agents in India, and that is why these designed supplements like Ensure Diabetes Care will have a vital role in the next 10 years, is because we are thin fat Indians. And when we give these agents, we are going to accelerate that muscle mass loss. And if you give these agents to people above 65, and if you lose muscle after 65, then you will increase mortality. So remember that when you are prescribing a GLP-1 receptor agent above 65, and if you are going to lose muscle mass, then you will increase mortality. It is absolutely necessary that you train that person to prevent muscle mass loss by weight training and resistant exercises, and give them adequate Ensure Diabetes Care 6 scoops or a muscle supplement and appropriate nutrition. That's very, very crucial. It's a very, very important thing, and I'm happy that you asked this question, because preservation of muscle mass is a key thing, particularly in our phenotype. We are thin fat Indians. We have less muscle, more fat, and that is why it is very crucial that we do this. And many of these supplements, as I said, work like meal replacement. Om very nicely put out some of these slides, and I'm asking Mo to take a few questions, and then probably I'll take a few others.
Right. So we'll take a couple of more clinical oriented questions first. Since we are clinicians here, there is a question on, is there a role in gastroparesis patients? It's a little tricky. Like sir said, there is an increase of GLP-1. Which can increase the worsening some of the symptoms in gastroparesis. So I'll be a little careful in patients who are having gastroparesis, and I'll probably again give it with caution. Is there a role of keto diet? Is what Dr. Rao has asked. Well, keto diet is an area. There are people who have lost significant weight with keto diet. There are people who have also had diabetes remission with keto diet, and there are several studies. It used to be very popular maybe I think 5 years back. It has lost momentum because it is very difficult to sustain. The problem with any form of nutrition when given for a long time is whether the person is able to sustain that as a part of their life. Why a supplement like this really works is because it becomes like a routine for the patient, and the patient can then sustain it as a part of the life. If you can sustain keto diet for a long time, it's difficult, it's challenging. If you can do it, great, it would be a good idea. If you can't sustain it, then it's, you're back to square one. So I think that's the problem with any nutrition. In fact, there's one senior nutritionist who once told me that if I write anything on a piece of paper, and if the patient follows it, anything if I write, and if the patient follows it 100%, every patient will lose weight. The problem is that, we don't always follow a routine. As long as you do that, you could probably win. Well, somebody has asked, and sir, would have your opinion as well? Would you recommend then that this in pregnant mothers? Now, if you see the product monograph, it says that it's safe in pregnancy, but have you used this in pregnant people?
We have data on pregnancy and it does very well because the glycemic variability in pregnancy comes down. So it can work in GDM. In fact, GDM, 90% can be controlled on diet and exercise, and only 10% need insulin. So, GDM is like you try to keep your glucose below, fasting below 90, postprandial below 120, A1C below 6 or 5.8, and it's actually two tips for GDM diets. Number one is breakfast, lunch, and dinner. You split it by half and spread it by 2 hours. So, if you have a content of your breakfast which you are consuming, say 400 calories, consume 200 calories with a 2-hour gap, and if you add 2 scoops of Ensure Diabetes Care 3 times a day in between snacks, it would actually completely blunt the glycemic variability. So prandial glycemic control is very doable, and it's prandial glucose which really hurts the fetus, and that's crucial. So I think that's very useful. We have data, it's not published, but it's work in progress.
Yeah, absolutely agree, and a great tip by sir. And I think, in fact, if I see my own prescriptions, I think the maximum prescriptions are in pregnant women, because that's where, very rightly said, the postprandial sugars are the one which are important. Another clinical question, and again, sir, your views on this. What about Ryle's tube feeding, right? Can it be given in Ryle's tube feeding? Well, again, from the product monograph, answer is yes. In fact, we have used it quite extensively in our, ICU patients also, and other patients on Ryle's tube feeding. So your experience with using Ryle's tube?
I think it's standard of care. In fact, if you see the ESPN guidelines, ASPN guidelines, we have people from IAPN here now, from Indian, this thing, probably Dr. Verma would like to make a comment there. Many of them, I think it's a standard of care in tube feeds. And, glycemic variability, if you use a conventional formula, you get glucose spikes, because many of them are sugar loaded and fat loaded. Because, in convalescence, we are trying to correct a negative nitrogen balance. But most of our population, and there is also hyperglycemia during critical care, so there are a lot of non-diabetic patients who get hyperglycemia just because of a critical care environment. And therefore, it's more important to use these compounds like Ensure Diabetes Care. And there is evidence base, and there are published studies there's a meta-analysis by Ely et al. Way back in 2005, which has been using it. So it's not something new. This is more than 30 years old, that in tube feed is where they started with, and then they moved to the community.
Absolutely. So I think, some of the other questions were almost covered in the, yes, sir.
So there's a question, very good question. Dr. Pratima is asking that whey protein is very popular. Nowadays, gym instructors instruct people on proteins, and there is something called creatine. So what's your opinion, and are there GI and kidney side effects of all these agents? And somehow, this is a feeling everybody has, that nowadays our lay people go on internet and Instagram, or go to their gym instructor rather than going to a qualified dietitian or a qualified doctor, and they take diet and dietary supplements. So your comments on this?
Yes, sir. This is blown up a bit. If you see again social media, there is a new protein company springing up every day, right? A lot of them are homemade brews by gyms and gym instructors. I think there's one doctor who calls himself Liver Doc. He's actually doing a study himself about a lot of protein supplements available in India, and saying that how many of them are actually safe. So what I'll suggest is, unless that the supplement comes from a standard source, right, from a reputed company with a reputed history and with a good clinical data to back it, I would suggest not to take it. That's my suggestion. We do not know, these are unregulated territories, these are uncharted waters. You don't know what harm they'll compose you, and as doctors and as clinicians, our first thing is to do no harm, right? So what I'll suggest is, to my patients, is that do not take anything which is unregulated, which has not been studied, where the composition is not very clear, where the company doesn't have a strong reputation. So be very careful with, a lot of these supplements which come from the gym, quote unquote, and that's my view on it. Rather, well, a lot of people, a lot of these things actually are nothing new. They're actually standard treatment, which is rehashed in a different way. People have some sort of fascination for experimenting in these ways. What I'll rather say is that use Abbott is a very reputed company since many, many years. It's been around. I think, when you have reputable companies bringing with this, there is a lot of trust in it. That is what we'll prefer rather than something which just comes out of the blue. So that's my take.
One last question and one last comment. So I think I'll ask the question to Om, and maybe I'll just give a summary comment. And it's a very, very good question. We are seeing that in India, people are more underweight than overweight. And, people are very protein focused. So this question says that don't you need to really balance? And I personally feel that's a very good question, because we are becoming overtly protein centric. And actually what we need is a balanced nutrition. So maybe Om, you could just highlight how some of these formulas are actually truly balanced in the entire macro and micronutrient composition. And then maybe I'll just give a take home message. The organizers are telling me that we are across more than 45 minutes, but maybe we are extending it by another 3-4 minutes, and we'll just answer this question. If somebody has a quick question from the audience, we'll be happy to take a comment or two from our nutrition colleagues who are here. If they want to make a comment or two, we'll just take that quick question and then we'll close the session.
Yes, sir. So though of course, a lot of our talk also was on protein. If you see the current, Ensure Diabetes DSN formula, it's actually a balanced formula. It is meant to be balanced, right? So you have good fat content, you have low GI carb, and you have proteins. So it's a balanced a meal in itself. It's not protein centric in that sense. However, like very rightly said, there is a lot of focus per se now on protein because we are generally protein deficient. Having said that, I really don't see that, that changing too much, because end of the day, especially vegetarians, we don't have too much of protein source. So even though if we try very hard, we are not going to go overboard with that. But having said that, I completely agree, especially for people who are normal weight or underweight. I think it's a good idea to have a balanced diet. Balance is everything. Fats are equally important. Carbohydrates equally have some role in patients. End of the day, patients do take carbohydrates whether you like it or not. That's why keto diet did not survive, because such low carbohydrate intake patients cannot accept, and it's very difficult to really kind of move ahead with that. So yes, balance is very important, and I think I completely agree that a balanced diet is as important as being centric on one macronutrient. Balanced diet is the way forward. But at the same time, in that balanced sense, we are generally protein deficient, and that's why that focus was a little bit on the protein end of it. But at the same time, balance is the way to go forward. I agree.
Thank you. I think I agree that balance is the key. I can see that a large population of you all still kept in. Thank you so much for waiting. If anybody has one or two compelling points to make, you can stand up. Yeah. So if you see Anjana's study, in India we consume very less animal protein, and it really doesn't matter as long as the biological efficiency of the amino acid composition is appropriate. Some of the animal proteins actually, though are animal sourced, unfortunately have more fat content. There is because they give these injections of oxytocin and this thing to the growth hormones, there is actually fat inside the muscle of the mutton or the chicken you eat nowadays. So that is the bigger problem in animal proteins. And now there is a big problem. There is another plant-based sources which are like pea proteins, but there is peanut allergy or pea allergy there. So we have to balance. So you have to decide which side of the fence you are. Are you the vegan, vegetarian, Jain, Gujarati, or are you the pure non-vegetarian like my partner at Lilavati, Dr. Padikar? He has breakfast, lunch and dinner non-vegetarian food, So it depends on which part of India you are from, what type of ethnic group you come from, what type of religion you come from. This is a very sensitive question. As long as you get a good quality protein, whether it is from animal source or from plant source, it's good enough. Remember, plant sources can have allergy, and protein sources can be pumped by some endocrine disrupting chemicals. So I hope I have answered that question. Any other quick question? So there is a National Egg Board, and egg white is a great protein source. Okay, you can chuck the yellow out, but if you want to grow your atheromas and block your arteries, take the yellow. If you want to build your muscles, take the white. Yes, Om, quick question on HMB.
Yeah, I think, again, there are smaller studies, even larger ones with specific, nutrient compositions which are there. I think, maybe in interest of time, what I'll say is that yes, there are specific roles in specific areas, but in specific clinical situations also. So that is what I will go about. Yeah, in a broader picture, maybe, yeah.
So, my mentor in Mayo Clinic, Professor Sri Nair, his cat is named Lucine. Okay, so that's important. One last point, somebody else had a raised hand. Any quick point from the nutritionist? Yeah, yes, ma'am. Thank you so much. Thank you. Thank you. Thank you. Thank you, everybody. We can have now good, sumptuous, carbogenic and atherogenic food.